But do they need to see everybody on their own every single day, every single patient?
They worked when they came in. Millions of Ontarians got attached to family physicians.
How do you know that they're going to do the pap smear just like I do the pap smear? Oh, I can't do that. There are no other increases for any of the other healthcare professionals. So you've been static, right? You've been static. So then why would anybody come in?
It's a very hectic time right now in primary care with the $213 million announcement that happened.
Exactly.
Was it 2 weeks ago? And
I think it's, we've got about another 2 weeks to get our proposals in. So it's, I don't think people really understand, I don't know whether you agree or not, just how complex primary care is. It's not simple with the different physician compensation models and the different primary care teams. It's not, a 3-minute conversation, that's for sure.
No, it's true, Duff. I think that's the challenge that people have is that the complexity is beyond their scope, and the other aspect of it is the fact that there is no primary care system. It's just a bunch of individual primary care provider clinics that are loosely scattered, and there's some kind of sewing going on, but it's patchwork.
Well, we have about 90 physicians, so it's 90 individual corporations tied together with the family health team. It's complex. I feel a little, I guess, not to jump right to it, but having had a long history in the ministry, and we put a lot of thought into the compensation models and the primary care team models, and they're not perfect. But I don't think they can be fairly judged when they haven't been invested in close to a decade. So that's kind of where I sit with this new model coming out. I'm kind of going, hey, I worked on the old models. I have an investment in those old models. So I have to recognize I might bring my own prejudice to the conversation.
So 2005, we started this journey, right? The team-based care, correct me if I'm wrong, but that's how I understand it, Duff.
That's right. It goes back a little further, Anthony, because first we changed the physician compensation model to support interdisciplinary team care. So it does go back even before family health teams. It was a well planned out strategy.
So this takes us to the early 2000s when this story of team-based care started in Ontario. And maybe you could, Duff was there working for the Ministry of Health at the time. Is that right, Duff?
Yeah, I was the director of family health team implementation, which again might be why I'm a little prejudiced. And I also was the manager of the physician compensation unit. So that also in turn might make me a little sensitive about the different compensation models we developed over time. I just felt like a lot of negotiation and a lot of time went into developing with a sense of someday having primary care teams. So we, I'll stop very shortly, but there's basically 4 physician compensation models in family medicine. That's fee for service, blended capitation, salary, and alternate payment agreements. And they each had their population. And this primary care teams, nurse practitioner-led clinics, family health teams, community health centers, Aboriginal health centers, they all had their purpose and they all had their design. So a lot of thought went into the structures that we have today. And I'll finish with, I just don't feel they can be fairly judged when they've been neglected for 10 years. They worked when they came in. Millions of Ontarians got attached to family physicians.
Where did it go wrong?
10 years without a base budget increase, 6 years without a salary increase. Med students, and Ivy will know better than I don't know why med grads are not going into comprehensive family medicine, but they sure aren't. And now the rest of the disciplines are following suit. We are not the employer of choice, not for nurse practitioners, not for mental health workers. It's just been neglected. So med students don't want to be family doctors, and other disciplines don't want to be part of a primary care team.
I'd have to say, Duff, though, I think part of when I remember the 2005 period of time, It was, get the family physicians who were individual practitioners, get them into FOs, kind of get them to start working collectively more as groups so that they weren't solo practitioners, give them an EMR, and then, hey, now you can become a FIT. Would you like to actually come into the FIT model, and we'll give you some healthcare professionals as well to work with you. So my recollection was it was a strategic sort of move to get the physicians to move towards this kind of model of care, away from the fee-for-service and getting it to capitation, right? But if I go back to the premise of team-based care, if you start with the structure, it's team-based, then what's the funding model for the team? And we start with the physicians. We always start with physicians. And then we always have to negotiate with the physicians. And then the physicians have to actually, and then the primary care docs, who are often part of the Ontario Medical Association, and they often aren't as strong as some of the other specialists that are there, right? Yeah. And so I think there were some real challenges of being able to articulate, one, what was the value proposition of a family physician, number one, for the to actually be paid well. Mm-hmm. Two, what if you're in a team, what does that mean? And three, what about the other team members? So I really think about the other team members, and now we're seeing it, Duff, that family physicians did get the increase, but there were no other increases for any of the other healthcare professionals. So you've been static, right? You've been static. So then why would anybody come in?
Doctors here who've delivered the grandchildren of people they delivered. So it's not an easy connection to turn their back on, and Ivy, I'll defer to you on that because you lived that.
We still continue to pay more and more and what are we paying for, and what's the incentives for it at the end of the day? And again, beyond the physicians, how is the equity for the other healthcare professionals that are working in these teams?
I think it's an accountability piece that's missing, because the payment models that I know, I don't think there's one of them that a dedicated physician can't do good work under and care for a lot of patients. And I don't think there's one that a physician that wants to manipulate it to their own benefit can't do it. So I think it's the accountability piece that's missing, not the models. You will hear accusations if they're on salary, they don't work as hard. If they're on blended capitation, they take on more patients than they can see in a timely fashion. If you're on fee-for-service, you're rolling them through on a business model. Mm-hmm. Any of those will work with somebody who's got a lot of integrity. And fortunately, most family physicians I've met, and I've met hundreds, have integrity. I've met some who don't, far too many perhaps, but I really think it's the ministry not holding them accountable to do what they're paid to do. And at the same time, I find the ministry makes rules based on what a physician might get away with, which in turn impinges on physicians who would never dream of getting away with that.
Right.
Yeah. Do you know what I'm saying? Yeah. There's rules that are directed at the 5%
yes.
to take advantage of
Absolutely.
Something.
And it freaks everyone else out who would never dream of, that's my words, but
it's offensive.
Yeah. But what do you think, Duff, of so I always use the example of I was lucky to be working within a family health team, but prior to that, I was always working in an academic center with a hospital. And so my rent, I didn't have a lot of overhead. So, that was good for me. Mm-hmm. And I was fee-for-service, but I didn't have the overhead. I had hospital nurses working with me that I didn't have to pay for, right? Mm-hmm. And so I think about, again, the way that the system has been structured. You've got hospitals that have the infrastructure and the payment for all of their healthcare professionals, and you've got all the services and the infection control, and the IT is all embedded within the hospital because it's a four-walled kind of structure. So build it, and then we will come. And with the notion of our training, so we train comprehensive care. We train all of our family doctors so that they're ready to enter practice and do generalist care. Right. Issue is they get a choice. Well, if the funding model actually is more to go work as a hospitalist, they're going to go work as a hospitalist. If the funding
And they
model
do.
is
It's a little bit crazy, actually, like to think that you go to school, you train to become a doctor, right? A clinician, and you're about to embark on your career, and you are about to walk in and learn that clinical trade. You're about to learn that, right? And now, in addition, you're an entrepreneur too. Here you go.
yeah.
There are models where there are salary models. They're just measured, I guess, in different ways than a faux model is. Faux, volume is a driver. Volume of patients rostered is the driver. And in a CHC, it's really more the morbidity and the needs of the patients that is the driver. And that's why they carry so much fewer patients than you would expect a faux physician to carry. So there's both models, but you're typically working with a different population by virtue of the model you choose as well.
And
That's been my experience.
And again, I don't have a lot of the negotiation components for myself, but I have to think about the principles of what we're trying to do and deliver the care. And I go back to the notion of if we're providing a practice and the ideal is comprehensive care, cradle to grave, right? Our family physicians who graduate are trained to do lumps and bumps. They work in emerge. They work in hospitalists. They do the chronic disease management. They work in the emerge. So you've got this incredible resource of this adaptable person who can do it all.
Right.
Right.
Yeah.
But they don't want to do it all, and yet
Absolutely.
we don't. Right. So the choice point, and that's where we lose. We've got many family docs, and they focus their practice for a reason, because there is a need for emerge. There is a need for hospitalists, right? And so we can go fit the need. But when you take that family doc out and they're not necessarily working in comprehensive care within a practice, then you lose one that's doing the comprehensive care. Right?
Right.
So in my mind, I just wonder about, here's your funding, folks. Here you go. Here's your population. Here's the people that you need to actually, you figure it out.
Yes.
You need a family doc who's not going to do obstetrics. Okay, then you get a midwife.
Right.
I didn't know what to do with that pharmacist. I didn't know what the heck to do with the social worker that was working with me, right? No. So how could I maximize and optimize the care if I don't even know what those people do? Right. And then there's the trust, right? Well, I don't trust that you're going to do what I do, right? We trained all of our nurses to be able to do well women exams, okay? Because that's in their scope of practice, to help us so that we could be able to take on other patients and they could do our well women care.
Right.
What was the response? Oh, wait a minute, don't know what they're gonna do. What if they make a mistake, then I'm liable for the mistake? How do you know that they're gonna do the pap smear just like I do the pap smear? Oh, I can't do that. And then I like to do my well women exams because they're fun, they're nice, and they're the times that I can connect with my patients again. And so you're this element of feeling loss or a change is what we're feeling as family physicians. However, if I could, and you think about the pharmacist, if the pharmacist could actually take on more of the chronic disease management, right? I could be freed up to do some other things. Now, does that mean that I'm going to only see complex care? Maybe not. I could have a practice and still be able to see my well babies, et cetera, as well. Yeah. But we're leveraging the scope of the other healthcare professionals to do what they can do to provide services at the right time and an earlier time, rather than, again, okay, come and see me, but my visit's going to be 4 weeks from now to check your hemoglobin A1C. Yet I could have had a chronic disease management specialist who could be the pharmacist be seen within a week.
Mm-hmm. Our doctors think the world of the 5 pharmacists we have. And in fact, was Moderna the first COVID vaccine? I can't remember which one came out first.
I think you're right.
But yeah, I called the 5 pharmacists on a Saturday and they were in the clinics on the Monday. working with the physicians to deliver those vaccines.
That's okay. You're allowed to.
Well, you know, I just, I struggle because I am a family physician, right? And I value that relationship. And I want to have that practice population that I can have that relationship with. The reality is we're not going to have enough family physicians so that everybody's going to have that experience. And so that's the reality. Okay, well, we need family physicians. I think that the scope of practice, the expertise of the family physician that deals with complexity, right?
Right.
That in fact, if you're working with the other healthcare professionals, the family physicians becomes a consultant when it's out of the scope of practice of the pharmacists and the social workers and the dietitians, et cetera. They need to come to us rather than referring to Emerge, right? So that means that our role as family physicians is going to be different. If we want to maintain having a valued role that is not replaced, then we need to optimize our knowledge and our skills and the expertise that we have and demonstrate that we're the ones who you come to when it's complicated,
Right.
when it's complex. But the patient population could be shared. So you could still have me. I may have, so David Price had said in the Family Medicine Forum last year, the vision might be one family physician for 8,000 patients, right? Whoa, 8,000 patients? Okay, well, let's just think about that, okay? Most of the patients may be young and healthy. They don't necessarily need to see the family physician all the time. Right. But they need to be attached to a family physician because they need to be able to grow. If there anything that is out of something that happens, then the family physician's available and they know who they are, right? Sure. But it's about a different way of working. And I still believe that the role of the family physician is so incredibly important as the generalist and the one that adapts to what is needed in the community and can actually be the one that takes on the holistic look of the whole.
Right.
The other healthcare professionals, they see parts. Mm-hmm. Someone needs to see the whole, and the whole as well as the complexity of care. That's the family physician's role. But do they need to see everybody on their own every single day, every single patient?
No, absolutely not. And I'm going to flip the question around a little bit, Ivy, because no more do they need to see everybody than does every patient need 45 minutes with a nurse practitioner or 45 minutes with the CHC professional. So there is some value. Like our physicians in the unattached patient clinic are seeing 30 patients a day. And those patients are happy because they're nice. The nurses are nice. I go see my doctor. I'm in and out in 10 minutes, and we talk sports for 4 minutes. So, and I feel well cared for, and I have complex conditions, and I'm in my late 60s. He gets $300 a year for me, and I haven't been for a CTAS 4 or 5 concern. I'll bet in 15 years to a hospital because he's accessible.
You're right.
And he's on top of, he's ready. He knows who I am when I walk through that door.
Is he
even have it? So even when we had it as within the family health team, there was still a need to understand, can they do that? What are we going to do with them? And there's no time to actually organize new ways of models of care. So we hire a whole bunch of these new people, new healthcare professionals, and then we just go about doing the old way of practice. With that, there's no efficiency in that. There's absolutely no efficiency.
We're just kind of tacking on to the structure, right? Is how I'm
and there's no capital investments. There's no capital investments, and we have 28 sites. We have 100 staff, 90 doctors, and 28 sites. Like, it is pretty helter-skelter, and there's been no capital to bring physicians and nurse practitioners and pharmacists, in most cases, all under the same roof, where you have that relationship building, you have that immediate access, you have the immediate ability to consult with one another. That's the way family health teams were meant to be, but there wasn't the capital investment. And then you ran into so many physicians own their own space, that they
Yeah,
couldn't move out without devaluating their property. So there are many, many hurdles. But
sorry, Duff. Real estate is a big barrier to centralization. It depends on how you see centralization, I suppose. I don't think it's possible to have everyone co-located. As much as I think I've seen it spread across a whole city, and I've seen it co-located under one roof, and I would say, yes, it's better to be co-located under one roof. But it's sure as heck better to have access to someone across the city as opposed to nothing. I'm not sure it's practical to get everyone.
I'm not proposing that we would collapse 28
No,
sites.
I'm not
into
saying you
one or
are
two or
either.
3 or 5.
Yeah.
But
Yeah, I would go back to the principles of what are we trying to deliver in the care. And so the element, again, going back to those 4 elements of primary care, whoever is connecting with the patient, the first contact, needs to understand, do they or do they not have the right skills to provide the care that is required at that moment? If they do not, then it is up to them to connect them to the right person who can actually do it. And that requires an infrastructure that is coordinated. There needs to be some infrastructure that ensures that healthcare professionals are coordinated and are able to connect with each other, right? And that fundamentally, I don't think is actually in the discussion. We're all talking about access and attachment. Okay, what about the things that come after access and attachment? Coordination, you need the continuity of care, and you need to ensure that you're providing comprehensive care. It's not just about parts, it's about the whole, right? We're there, and we do that collectively together. Could we build trust? Yeah, I think we could build trust. Could we leverage, so let's put that training component together. What about things like collaborative practice agreements? So collaborative practice agreements have been used by regulatory colleges so that I, as a physician, could actually create a collaborative practice agreement with the pharmacist who I may or may not know very well, but that's building a bit of trust if I have to sign something with you to say, we're going to manage our shared patients collectively like this. You and I, and we're going to do, this is the best practices for a chronic disease. This is how I wanted to look at my medications, et cetera. And you can repeat them without actually worrying. You'll contact me. I'll pick up the phone if you call me, right? Mm-hmm. There are things that we can do to build opportunities of trust, to build the coordination elements of it. But the system needs to actually ensure that is part of the infrastructure. And primary care right now is all about attachment.
Right. Because there's is it an ROI, not an ROI, what is it? An RFP or EOI, $213 million to expand attachment, really, which means grow fits largely, and CHCs, largely, that's what it means.
I would say it's a quantity exercise. It's not a quality exercise. Numbers of attachment, to Ivy's point, are the driver, and I agree with Ivy. I guess if I got one criticism I have more than one criticism of the Family Health Team launch all those years ago, is the minister called every day to find out how many more Ontarians were attached, and we certainly had attachment go up and time between appointments widen. So, there's always a cause and effect. More people had doctors, it took longer to get in to see them.
I know attachment is the metric, of course. And I'd like to obviously count that, but what about the ones that we lose in that time period? Like, we're going to be counting people in the network who attach more patients. Right? What about the people who aren't in the network, who have apathy, and they're done? We're not counting those. So it's unclear if there's a net gain. There might be, but it's unclear because we're counting the ones that are gaining and not counting the ones that are losing. It's kind of like if I were doing the books, you only count the income and not the expenses.
That's a good point, Anthony. When I came 4 years ago to Peterborough, there were, I believe, 116,000 patients rostered and 97 physicians, and now we're down to 99,000, and 9,000 rostered, and 87 physicians. So when we get credit for raising this count under this new initiative, we're really trying to get back to status quo. Uh,
But I get back to that you increase your roster,
Right.
and then how long does it take for you to be able to see that particular patient, right? And so that gets back to the efficiencies related to that. And if we don't change the way that we practice with those other healthcare professionals, it doesn't matter how many you roster. If they still think that they're going to need to be able to see the physician at all times,
Right.
then if you've got a roster now of 8,000 people,
Yeah.
you're going to be one and that's what's actually happening. You hear it all the time. I'm attached, but
Right.
I can't see my family doc.
Right.
I can't see anybody who I know. But what if you actually were attached to a team of providers who got to know you? And a team, I'm going to say, is like, family doc, nurse, pharmacist, could be like a core. Like, what is the core that you need? And so I get back to the whole the training
Yeah.
for all of these new other health professions that
Yeah.
are not family physicians,
Right.
who in fact don't have mandatory training in primary care.
Nope.
They don't have to work. They don't ever have to ever step
They
into.
train in the hospital.
They all train in the
Yeah.
hospital.
And then they go work in community care.
And then they don't
that's a
know,
challenge.
right? And they don't
Yes,
know
it's a
what
challenge.
community care
Absolutely.
is, and we don't have the professional development. They go back to the family doc again or
Right.
somebody else to say, "Well, train us." Well, we don't have the time to do that either.
No.
So there's no structure for the training and the upskilling that's available for them as well.
Training as a social worker, they're training as a family doctor, they're training as a nurse practitioner. But the model that they're telling us that they want is for everyone to work together and support them. But we're not training them like that. And it takes years and years once you hit the field to develop something like that. And it takes a lot of physician sweat equity and willingness to work in that model. It takes years and years and years.
So I'll adapt it just a little bit
Please.
because many of the family medicine residents right now are trained within team-based models. Okay, so but the teams are practitioners. So they would work with a nurse practitioner. They have access to the dietitian, so they can learn how to do that. Okay, and then they go out, and that model isn't available to them. Okay, so let's say the model is available to them, and we're ramping up, increasing the numbers. Right. Well, you're going to have to hire social workers, nurses, pharmacists, etc. The issue is those pharmacists and social workers and nurses and dietitians, etc., have never trained in a family health team model. We don't have incubators that are for all of the health professionals working within this kind of team-based primary care model. We train currently, and if you look at, we train family physicians, and the model of training for funding those family health teams that are academic are for the medical students and family physicians. If a social worker wants to take on a learner, they may not even have a relationship with the faculty of social work.
Yeah, I've experienced that. You have
Right?
to establish that.
Or do they get any funding or any incentives for training their own?
No, not much.
But
It's
there's
case
an
by case.
No,
right?
all of our disciplines take learners, but they don't get compensated for the additional work. It's their commitment to the profession.
So when they go, when their learners are there, this is the next level of training, right? Do the social worker learners and the pharmacy learners, do they actually come together with the family medicine residents and the medical students to learn collectively together?
I don't think that's the way it works. I think that we're so spread out where our social workers are. It's almost like they're different agencies in some ways. So the family medicine residents work with the family physicians in the family physicians' offices. Some have other disciplines co-located with them, some do not. But I'm going to say, as a rule, they probably spend most of their time with the family physician.
This is the first time that the OHTs are running as quarterback, is the term I'll use for an EOI. They've been involved in the past, but they're not running it. So So that is a step to that, right? We have to acknowledge that that is a step. It's a really hard problem, very hard problem to solve. So what would you like to see out of this? Other than a few more weeks of time to fill, to get to work at
Yeah,
it.
I would like to see the opportunities that we have in front of us, but I know they're going to end up being vacant positions. I love the opportunity that I can build more disciplines into our team, that opportunity will be there, and family doctors will be able to work with you. I mean, our family doctors right now, our nurse practitioners, they're spread across 3 and 4 doctors. Like there's just, I mean, it's in 3 and 4 locations. It's just not feasible. So to have more disciplines, great. To have good morale, but I'm afraid I'm going to inherit a bunch of vacancies, and the doctors are afraid they're going to take on 500 more patients, and there's going to be vacancies sitting there that were supposed to be there to help them provide comprehensive care. So what I would like to see, I hate to get it back, I would like to see it be FITS, CHCs, NPLCs to be the employer of choice for many of the health disciplines. And, we can work on all the other flaws that are in that system, and there are plenty, but let's get it populated and let's get people involved in helping to make the change and caring for patients while those changes are being made.
Okay. Supporting the FITs, supporting the CHCs, nurturing, cultivating the structures that we have, because they need to be given a fair shot in order to work as they are designed. Is that fair?
And NPLCs, I never like to leave the NPLCs out. So they're part of it, part of the solution.
Ivy, 213 million. That's a lot of money. 1.8 billion announced. What would you like to see out of this?
So I think, first of all, you need bums and seats, right? So we need to make sure that those positions are filled, and ensure that you now have a interprofessional team. I would like to make sure that the ministry gives those teams enough support to actually change the way that they work. They're not just putting bums in seats. They're saying, okay, you're here now. Let's work differently. And to work differently, you're going to have to figure out what you all can do. And you have to figure out new ways of coming up with work processes and care plans that might be different than what you often did in the past. They need some time. 4 weeks to put a proposal into place, and then you put all these people in, and then there's no time built in to design a new way of working that can efficiently provide the kind of care that we're looking for. And so what I would like to see is that there's not only an incentive to attach, but an incentive to actually provide good, effective care. And that, if people aren't able to do that, and I think that's one of the things I saw with the very original family health team evaluations, right? We evaluated them. They said they didn't work so well, but why? Because they just put people together and expected them to work together and never provided them any support for changing the way that they worked, or changing their behaviors, or changing their stereotypes of the other healthcare professionals so that they wouldn't work with them. Right? So for me, this is a whole culture shift. And if you really want to invest well in the money, don't just give it to the people without actually having the infrastructure and the kind of supports that are required to change the culture of care in primary care.
Yeah. Like the announcement itself is not the result. I feel like we act like we announced the money. Okay, done now. Or like that's not actually the result. Money itself isn't going to solve the problem. I don't think there's anyone working in the system who thinks it is. Do you think
we have the 6,000 people who we've served in the unattached patient clinic, and we don't even know if they're on Healthcare Connect. We didn't ask them if they were on Healthcare Connect. We asked them what they needed for care.
Right.
And now we're supposed to focus on Healthcare Connect. We don't have their records. We didn't check it off. So we're at a disadvantage. We got 6,000 people who are going to get enrolled attached, and I know attached isn't the end of any good care story, but we don't even know if they're on Healthcare Connect, and that's supposed to be the priority. So
Got it.
I don't know.
Understood. Ivy, do you think, and that's really good to know also, do you think that with the OHTs running this EOI, do you think that they could have a role in that accountability structure for ensuring that the clinicians of all disciplines can work together? It would occur to me that they're a natural question, at least to ask. Do you think the OHTs could play that role in helping the clinicians work together as a team, or learn or focus on that for a time period?
I'd like to believe, Anthony, that they could. But what I'm seeing across is that there isn't a playbook. People are they're just flying off the seat of their pants of trying to figure out how to actually, we've got all these people now. What do we do with them? And there isn't resources and tools and courses or even facilitators. We know that there's good evidence if you have a practice facilitator who help and coach the teams. That makes a huge difference. Will the OHTs have practice facilitators available for all of these new teams? Will they have abilities to upskill, right? So if you've got nurses and pharmacists and social workers who may not have never maybe have worked in these family health teams in the past, the OHTs have an opportunity to pool themselves and say, we will be your human resources department.
Right.
Like a hospital would have for your skill upskilling, right? Why is it to each individual fit that will be doing it? The OHT can do that. So for me, the OHT could do that. They could be the place which helps them with their quality improvement, to look for the data components of it, to be able to combine those things, to ensure that there's a standard of care. And I go back to, there is a primary healthcare standard, right? We have a national primary healthcare standard. Nobody uses it. Maybe the CHCs will use it, right? But any average family doc practice, there are no standards that we need to look at for practice. Okay, we're maximizing or optimizing these huge numbers that are out there, and there is no standards.
What about the CPSO?
Well,
Help
I'm
me
talking
understand.
practice standards.
Help me understand the difference.
So CPS. So you have standards for your profession.
Yes.
For you and how
Right.
you actually practice, right?
Yep.
But the organization of the practice. So hospitals have hospital accreditation. They have to,
Understood.
right?
Accreditation Canada.
Right.
Right? Yeah.
But your average practice, or your nurse practitioner-led clinic, or your pharmacy-led clinic now, or your family doc clinic, we don't have standards that we need to keep. And that playbook, I think the playbook could be part of the standards, but I think that's what's missing. I would love to be able to see an approach where there is some principles of how you need to give good primary care. And we do have research in that, We know what high-performing primary care systems, how they function. Okay, well, use that as kind of your outcome. And how do we actually build that now? And the OHTs, that I think is their role. They're like the engineers to help support the providers that are within their communities.
Our local OHT is really just a table of executive directors and one hired OHT executive director. I don't think they have the skill set or the mandate. I certainly don't. This would take a team.
Got it.
For sure.
Got it.
And it also has to build in, there has to be accountability. So it's not just having the standards, it's holding
Accountability.
groups, organizations responsible to meet those standards. I've been around long enough, as has Ivy, that there's agencies that run at the top of their game, and there's agencies that don't do that at all. The only thing I know for sure is I know what I want, and I want everybody to have good primary care, good, accessible primary care. That's the only thing I know for sure is what I want.
Awesome. Okay. So, thank you. Appreciate
Thank you, Anthony.
coming.
Ivy,
It's a lot of
nice
fun.
to see you.
Nice to see you again, Doug.
Okay. Till next time.
Okay. Maybe I'll
care.
come in person next time.
Yeah, that'd be great.
Look forward to it. Okay.
Bye-bye.
See ya.